I was asked today to talk about novel treatment approaches in ALK and ROS1 positive non-small cell lung cancer. Here are my disclosures. And whenever I give a talk on any targeted therapies, I always start out with testing because if we can't find it, we can't treat it, right? So it's really important to ensure proper molecular testing. ALK and ROS1 are important biomarkers to check, as you can see right here. All right, so what is an ALK fusion? So when a fusion occurs in ALK, it activates downstream pathways and promotes cancer growth. ALK fusions are known to occur in 3 to 5% of non-small cell lung cancer patients, often in younger men. As shown in this diagram, multiple drugs have been approved for ALK. This is the NCCN guidelines. The NCCN guidelines list alectinib, brigatinib, or lorlatinib as the preferred Category 1 recommendation for first-line use. Category 1 means that it is based on high-level evidence, and there is uniform NCCN consensus that the intervention is appropriate. So first, I wanted to start by looking at ALEX. ALEX is a first-line study that compared alectinib against crizotinib. In the initial publication, the investigator assessed median progression-free survival was not reached, and the blinded independent review was median progression-free survival of 25.7 months. The final analysis, published in 2020, reported an investigator-assessed median progression-free survival of 34.8 months. And of note, the blinded independent radiology review of PFS was not repeated beyond the primary analysis. Now let's look at the data of CNS activity in ALEX a little bit more closely. In the intention to treat population, the 12-month cumulative incidence of brain progression was 9.4% with alectinib and 41.4% with crizotinib. In those who had brain metastasis at baseline, the cumulative incidence at 12 months was 16% with alectinib and 58.3% with crizotinib. While in those who did not have brain metastasis at baseline, the cumulative incidence at 12 months was 4.6% with alectinib and 31.5% with crizotinib. Now moving on to brigatinib, ALTA-1L was the first-line study comparing brigatinib against crizotinib. The initial publication reported the blinded independent review committee assessed 12-month progression-free survival to be 67% with brigatinib. From the final analysis published in 2021, the blinded independent review committee assessed median progression-free survival was 24 months. The last ALK-related phase 3 study that I wanted to review was CROWN, and CROWN, as shown here in the study schema, basically compared lorlatinib against crizotinib. Of note, asymptomatic, treated or untreated brain metastases were allowed. From the interim analysis of this study, the median progression-free survival of lorlatinib, as assessed by, again, the Blinded Independent Review Committee, or BIRC, still has not been reached, and this is at a follow-up of 36.7 months. The hazard ratio by Blinded Independent Review Committee for the overall intention to treat population was now at 0.27. The hazard ratio of 0.27 is something that is very, very strong. Hazard ratio of 0.27 in this setting means that lorlatinib provides a 73% risk reduction of progression when compared to crizotinib. Of note, the 24 months progression-free survival rate of lorlatinib was 68%, and 36 months was at 64%. Here is data on intracranial progression, or I should say lack of. The curve showed the time to intracranial progression, and the median time to intracranial progression obviously has not been reached for lorlatinib-treated patients, again with a very low hazard ratio of 0.08. Why is this important? Well, obviously, preventing brain metastasis is important, but it really is important from prevention of symptoms standpoint. So this slide shows results from a retrospective study of 213 ALK-positive non-small cell lung cancer patients with brain metastasis who were treated on crizotinib. And as you can see here, the incidence of symptoms such as fatigue, nausea, vomiting, headaches, pain or numbness, altered mental status, seizures, and others significantly increase post-brain metastasis being diagnosed, which supports the clinical importance of preventing brain metastasis in order to protect the quality of life of patients. So how does it compare? Here is a table comparing alectinib, brigatinib, and lorlatinib. While cross-trial comparison should be done with caution, the cumulative incidence rate of brain progression as first event at 12 months is lowest at 2.8% with lorlatinib when compared to alectinib 9.4% and brigatinib 9%. Here is a little bit more deeper data on the CNS data from CROWN. In the intention to treat patients, the 12-month cumulative incidence of brain progression was 4% with lorlatinib and 34% with crizotinib. In those who had brain metastasis at baseline, the cumulative incidence at 12 months was 10% with lorlatinib, whereas it was 73% with crizotinib. And in those who did not have brain metastasis at baseline, the cumulative incidence at 12 months was 1% with lorlatinib and 19% with crizotinib. When talking about lorlatinib, I think it is really important to also review the adverse events, especially CNS-related adverse events. As shown here, CNS adverse events occurred in 39% of patients in the lorlatinib group, and most were grade 1 to 2. The most common CNS adverse events were cognitive effects, speech effects, and psychotic effects. In an analysis of 103 treatment-emergent CNS adverse events in the lorlatinib group, 59% required no intervention, 15% required dose interruption only, and 14% required concurrent medication only. Here are some tables and figures, again comparing alectinib, brigatinib, and lorlatinib in the first-line setting. Again, while cross-trial comparisons should be done with caution, lorlatinib appears to have the longest PFS, and it may matter when you get it, as lorlatinib post-second generation ALK TKIs have shown a median progression-free survival of only 5 to 6 months. Now, is there a fourth generation ALK inhibitor coming? And the answer is yes, there is. Nuvalent 655 or MVL 655 is a novel brain-penetrant ALK inhibitor, and it is designed to remain active in tumors that have developed resistance to first through third generation ALK inhibitors. It can treat solvent front G1202R mutation or compound mutations, and it inhibits ALK over the structurally related tropomyosin receptor kinase or TRK family to avoid TRK-related CNS adverse events. MVL 655 is currently being investigated in the first-in-human phase 1/2 ALCOVE-1 study.